and I'll be talking about special consideration in ACL injuries and management with respect to female and adolescent athletes. Next, please. We all know that ACL injuries are mostly non-contact in nature, about 70% of them. And if we have age-matched adults, male and female athletes, we see more numbers in females. The rate of injury is about 8 times higher in females compared to males. In certain sports, BJSM produced one article last year. They say more of it's like 1.5 times higher. If we see one article in AJSM, it says that if you study adolescent group of athletes, junior athletes, and then if you study between genders, we see similar trend in adolescent athletes as well. Next, please. ACL graft injuries and revisions are also quite high in female athletes. And they show lower percentage of success in their return to sport compared to the pre-injury status. Next, please. So what are the burning questions here? One is how do we reduce re-injury rates? Second, the secondary injuries. Contralateral ACL gets injured, or through the mechanical chains, they might have some other lower body injuries. And the third is successful return to sport compared to their pre-injury status. These are some of the examples of famous female athletes who sustained re-injuries, or they had contralateral knee injury, or some other injuries in the lower body. Caroline Marine, you all know these athletes. Caroline Marine, Deepa Karmakar, she had injury at a very crucial stage, could not participate in her last Olympics. Megan Rapinoe, she's a very famous soccer athlete. And Lindsey Vonn, she's an alpine ski racer, 4 times world champion. Those of you who have come from Pune, or those of you who follow badminton, they would know Sanyogita. Next, please. Sanyogita sustained 5 surgeries, multiple injuries actually, 5 surgeries in 10 years at a crucial time in her career. She was really brave throughout the process, but body and brain has its limits, so she had to say goodbye to her sport, took early retirement last year, and now she's trying to become a coach in badminton. And it's not just a story of Sanyogita. There are multiple female athletes, elite female athletes out there who are struggling with injuries. And many of them have to say goodbye to sport, hung their boots, and they take early retirements. Next, please. Sorry for a plain and lengthy slide there, but these are all the anatomical differences that I could list down. The research shows that these are the various things which are different. You can take a photo of it. Which are different between a male and a female athlete. Interestingly, how much ever research has been produced, in the past, none of the researchers or, cluster of researchers, they indicate that this particular factor is the most crucial factor, and that's why we have higher rates in female athletes. According to me, the last 3 are probably, the most important ones. They have tendency, Satyaj already covered in his talk, a little bit about female athletes, and he showed you the video. Female athletes do have tendency to go into dynamic knee valgus. They have quads dominance pattern and hamstring weakness, so functional hamstring and quadricep ratios are off. Another key difference is the mechanics of it. In the activities like running, cutting, landing, jumping, there can be a big muscle imbalance. The timing of muscle activation, the recruitment pattern of these muscles can be off between females and males. And if you read the structural differences again, you'll find that some of them are also true for adolescent athletes. Boy or a girl, but some of them are true for adolescent athletes as well. And the last 3 are true for adolescent age group. Next, please. If you see the bottom picture, consider this female also has subtalar pronation. The tendency to go into dynamic valgus would be much higher. You work on one joint above and one joint below, and what you would achieve is, next slide please, is dynamic knee stabilization, which forms one of the very important strategies when we are dealing with ACL injuries or management. management of recurrences as well. Maintaining functional hamstring quadricep ratios, Chandan already spoke about this. Isokinetic devices are really helpful, and maintaining those ratios can be very important. Neuromuscular training programs, really important strategy. Football has already shown that you can reduce rates of ACL injuries in females largely by addressing prevention strategies from the younger age groups. You have to address ankle and hip joints, as we already saw. Bracing can be a really good option if you want protection and confidence, if you want to give confidence to your athletes. At times it's required to brace them. Delayed return to sport is one of the very important strategies. Those of you who are interested in this topic, please go back and read more about it. Delaying, but judicious delay. It's not that you just keep on holding them back, that, oh no, you're not ready, you can't play. You have to wait till like 9 months, 10 months, 12 months. Thoughtfully programmed, delayed RTS can be a really important stage. As physios, we have to understand, do we have gender and age-specific rehabilitation strategies? We have to start formulating and implementing. Next. So we understand that there are multiple structural differences. We also have a lot of science to back it. We also have, based on those structural differences, we have orthopedicians, formulating different procedures. We have been doing that for years. But still, we have higher rates of ACL injuries currently, especially as more and more females are taking up professional sports and playing it at elite level. And also, we struggle with the successful return to sport. I think Chirag mentioned that about 70 to 80% of his athletes go back to competitive sports. He did not mention male or female. If we see foreign literature, it says about 60%, 40 to 60% of elite female athletes go back to pre-competitive levels. Next, please. So then why are we struggling? We have good, we know structure differences, we have good rehabilitation protocols, and why are we still struggling? Because we have to look at the larger picture here. We can't just be focused on structure differences female athlete shows. We have to look at much larger picture. Hormone being like a hot topic out there in research currently. But according to me, most of the research is very, very inconclusive. Genetic predisposition, females have genetically they're predisposed to have more injuries. Read 3 that I have marked in red: psychological factors, neurocognitive deficiencies, and socioeconomic factors. I feel these are really important 3 factors when you're considering a female athlete and also considering a junior athlete. How many of you have worked here with females, extensively, traveled with female athletes, individual female athletes at clinics probably? Those of you who have seen females going through injuries, not just ACL, any injury, you would know that, they show greater anxieties. A psychologist is going to speak after me, and I'm sure he will strengthen this point, but they show greater anxieties. There is also this overwhelming loss of self-worth. If you are treating a female, might happen in clinics as well when you're treating, non-athletes. But female athletes do show particular psychological traits which we have to, understand first, separate them from male athletes, and have to work on it. Next. Relative energy deficiency in sports, a very, very important topic. Earlier used to be called female athlete triad, but now we know it's no more a triad. It's more like a spectrum. And if you consider that why, not females, males as well, why do they get re-injured again and again? There is something called a higher fatigue system, central fatigue system. And we have to understand that what are the factors that lead an athlete towards a central fatigue. And this can be really important factor when it comes to females, when it comes to junior athletes. Some of the male athletes will also show this spectrum, by the way. Next, please. If you have a case of relative energy deficiency, you must understand that slower return to sports protocols is the key. You have to have a multidisciplinary team. You can't just be the sole person working with these athletes. You have to have a multidisciplinary team to work with them to get the best of the results. Next, please. I was talking about socio-economical factors. These are all the social factors which are out there when we are thinking about women's sports and junior sports. Most of the pointers you will see exist because of underdevelopment and underinvestment in these two categories. There are always budget constraints. When it comes to female sports, I know somebody from the administration is sitting here. Whenever there is talk about female sports and junior sports, there will always be a budget constraint. And because of which we see there are less training sessions, questionable quality and programming of these sessions, who is tracking the workload of these athletes. Less practice games, questionable quality of support staff, many a times, quality of infra, surfaces, pitches, equipment, footwear, sponsorships, and compensations. This forms a very important part in athletes' life. Samaira is sitting here with us, and she would agree that they need to get rewarded, and they need to get rewarded through money. It's a very important part because it's going to play on psychology of that athlete. And as I was talking about central fatigue systems. Psychological stressors are not good for performance. Next, please. So please understand that there is a big picture there. I've been working with elite sports for 16 years now. Male, female, junior sports, I've worked with all three of them. I can tell you there is a big gender gap when it comes to sports. Sarah Richardson is a person who has started Gender Sky Lab at Harvard. I would like to quote her. We knew from previous research that the real story is usually a complex entanglement of social factors with biology. And that's why we see these injury disparities among male and female athletes more so, is my opinion. And I agree completely with Sarah. Next, please. Shweta gave a very nice presentation. She told us about the objective measurements that we need to keep in mind when we are thinking about return to sport and return to performance. So that's a part of, the surgical outcome is done, the orthos have done their job, physios and SNC, they have done their job. You have the great, best objective data out of the athlete. He or she is ready to get into the sport. But please do understand nutrition and internal health of that athlete. I was talking about relative energy deficiency in sports previously. The psychology of the athlete, it's very important. Most of us, we do not work in collaboration with a psychologist. The social factors around that athlete, understand the background of that athlete and the ecosystem, how strong the support and ecosystem of that particular athlete. May it be female, may it be junior athlete, may it be a male athlete. Next, please. Next. Just a quick thought about adolescent athletes because the orthos did not cover it in much depth. We all act like a knee counselor, especially orthopedician. They have to identify patients at risk. They have to establish skeletal maturity through various means and understand the status of physeal closure. That's really important one there when it comes to surgeries for adolescent athletes. Next, please. These are my references. And next, please. Chiku and I say thank you to all of you for your patience. I just want to end the presentation with a closing note that especially about junior athletes. They form a very large pool for your talent pool for the country for future. And it's yours and my responsibility to provide them with the best of the support and care. So please do make sure that you study female athletes and you study junior athletes. Don't keep it as an option because we are responsible for the future talent of India. And the country can't afford to lose the talent. Thank you so much.
Thank you.